Alright, let's continue from where we left off in part 1 of the rounding video. Let's begin by talking about how to present 24-hour labs in imaging. And let's talk about labs first. I like to break this down into routine labs, non-routine labs, as well as trending labs. So routine labs are labs that you pretty much get every day, and examples of this would be a CBC, a BMT, an LFT, or a coags. And when I present routine labs, I generally just talk about the most recent one, which most of the time will be the AM labs, drawn at around 6 AM. Examples of non-routine labs include HIV tests, troponins, etc. I like to mention all new non-routine lab tests within the last 24 hours. Labs are being trended, such as a sodium level that's being checked every 4 hours for a patient being managed with hyponatremia. I do like to mention something about the trend. For example, patient sodium has been trending from 120 to 150 since yesterday, the most recent value being at 125. It's also nice to have relevant previous values, as this can be helpful as well. For example, patient's white blood count is 15 this morning, down from 17 the previous day. Don't forget to talk about cultures, including urine cultures, blood cultures, and peritoneal cultures. It takes urine culture results up to 3 days to be finalized, and 5 days for blood cultures, so you have to follow these for 3 and 5 days respectively. For imaging results, I like to summarize all new results within 24 hours. So that would be CTs, that would be chest x-rays, MRIs, ultrasounds, and any imaging result. Now, I'm at the point where I'm comfortable and my supervisors are comfortable with me not going over each component of each lab test individually. But if you're just starting, your supervisor might expect you to do so stay flexible and open. An example of how I present my lab and imaging results is the following. Patient CBC, notable for a WBC of 13, down from 15 yesterday, otherwise normal. BMP and LFT are unremarkable. Patient's glucose level has been running a little bit high, between 210 and 220 overnight. Urine cultures and blood cultures show no growth at 2 and 3 days respectively. The PHS X-ray showed normal cardiopulmonary findings. Now, we get to the most frustrating and challenging part of being a medical student, and that is coming up with an assessment and a plan. There's an enormous amount of variability and subjectivity to this. And what is considered an amazing presentation by some will be considered a horrible presentation by others. Again, I can't emphasize enough the need to keep an open and flexible mind, but I also want to stress that this is something that will come with experience, so just keep on pushing to get better by emulating those that are better and more experienced than you. Now, there's two issues at play here, the knowledge component as well as the organization component. I'm going to focus purely on the organization component, as there's no way I'm going to be able to fit something that takes decades of education to master into a nice 7-minute video. Let's talk about the assessment first. This is where you talk about the patient's differential diagnosis, as well as put your foot down to what diagnosis you think your patient has, and support that claim with evidence such as lab findings, exam findings, imaging findings, or the patient's history, etc. And then give a general idea of what you want to do for your patient to make him or her better. Most of the time though, you and your team already have an idea of what your patient has, as they've already been admitted, so you don't need to present a differential diagnosis. In this case, the point of the assessment will be to say if the patient is getting better or worse on the current treatment plan. If there are new symptoms or development, this is the place to talk about what you think the cause of that is, what evidence there is supported, and what you want to do about it. In many patients, it'll be easy to decide what the focus should be on during the assessment portion. But for complex patients or patients with numerous active medical issues, it can be daunting to decide what to talk about. My advice is to combine issues as much as possible and to only focus on the most important issues. For example, instead of talking about lower extremity edema as well as shortness of breath in a CHF patient separately, combine these issues into one, such as worsening CHF, which is evidenced by leg edema and shortness of breath. An example of how I would present my assessment is the following. The patient is a 67-year-old male with a past medical history of alcohol abuse, AFib, diabetes type 2 and hypertension, who is being managed for alcohol withdrawal on an Ativan assessment scale. The patient is responding to treatment well, as evidenced by decreased need for Ativan today compared to yesterday, as well as decreased physical symptoms such as tremor and nausea. Continue on the Ativan assessment scale and multivitamins, but will start preparing patient for discharge probably tomorrow. His glucose levels are elevated and will need to be better controlled. Notice that I mentioned what my plan was in very general terms during my assessment, which is a nice bridge to the plan part of the assessment and plan. I like to talk about my plan in general terms at the end of the assessment to give a big picture idea of what I want to do for the patient, but then I dive into the actual details during the plan part. I organize my plan by problem list, in which the most important problems as well as what actions I want to undertake for each problem are talked about first, although some attendings will ask you to go by organ systems instead. I'll have another video on problem lists at some point as well. Just like in the assessment part, for some patients there'll be a large number of problems, and so it's daunting to decide what's important to present and what's not. If the problem in question has been stable, with no new changes that needs to be addressed, it's probably okay not to mention it. Again, focus on the most important problems first. So for example, my plan for his alcohol withdrawal will be to discontinue scheduled Ativan, but continue with as needed Ativan from the Ativan assessment scale, have social work see the patient to help find a rehab center, and arrange for an appointment with the patient's PCP for follow-up after expected discharge tomorrow. For the patient's diabetes, I would like to increase his long-acting Lantus insulin from 10 units at night to 15 units at night. So in part 2 of this video, we've gone over the bare basics of rounding and how to present on rounds. This in no way tells you everything you need to know, but it should give you a foundation to build on. Remember, everyone has personal preferences as to how to present, and you will likely figure out what works for you and what doesn't as you build up more experience. Now, here are our take-home points for today's video, in which we've listed out what we've covered. Please take some time to look at this. Thank you.